Buenas tardes, muchas gracias por estar aquí con nosotros y me da un especial placer realmente de tener aquí con nosotros a un amigo ya de muchos años del colegio, Enrique Marcelli. He's professor in San Diego State University. I will talk a little bit in English because I need to present in English his short view of Enrico. Enrico Marcelli is an associate professor of demography and survey research methodology in the Department of Sociology at San Diego State University. He was formally trained in economics and public policy in USC and social epidemiology in Harvard University, and his work focuses on estimating the number, characteristics, and economic effects on unauthorized U.S. migrants and the economics and sociogeographic sources of health among immigrants and other hard-to-reach population. Dr. Marcelli has published more than 50 academic articles on immigration, work, and health, was principal investigator on the 2001 and 2012 Los Angeles County Mexican Immigration Health and Legal Status Survey, and 2007 Brazilian and Dominican Immigrant Health and Legal Status Survey. He is a co-editor of Informal Work and Developed Nations and has a previously held position in UCSD, Center for U.S.-Mexican Studies, UCLA, Lewis Center for Regional Policy Studies and Drug Abuse Research Center, and UMass Boston Department of Economics. So it's a long, more CV. And Enrico wants to talk in Spanish, but I don't know if he can wants to do this here. Ya le dije que lo que se sienta más a gusto hablando, si en inglés o en español, él lo puede hacer. ¿Ok? Pues, a eso le saldría más fácil, seguramente. Bueno, gracias, Enrico, por estar aquí con nosotros. Gracias. De veras, muchas gracias por acompañarnos aquí en el colegio. Y bienvenido de regreso.
Gracias, Josué.
Okay.
Sí. Gracias para invitarme. Lo siento, pero es imposible para mí hablar español para más que un minuto. Entonces, I'm going to speak in English because I don't want you to be here for 3 hours. And most of you understand English. And it is really good to be back at COLEF. I was a graduate student more than 20 years ago when I first met some people sitting in this room who taught me really the core of what I'm going to come back and share with you now 20 years later. And that is the truth. As a graduate student, I learned how to work with community-based organizations, how to collect sensitive data from legal and what I now call unauthorized migrants from some of your professors, some of your colleagues here at COLEF. There were 2 Jorges, I think. There was a Maru. There was another Chuy, Jesus, was it?
Jesus Montenegro.
Yeah, these were the people I learned from. And this has been the core, really. I did my PhD in economics and demography, but this has been the core that has really led to me having an academic career. I've built on that over all these years by then going to study social epidemiology, as Rodolfo said. But listen, I could reminisce and be nostalgic for a long time. That's not why I'm here. I want to really thank you for inviting me back, and I'm hoping that this is the beginning of a reestablishment of a relationship that's going to be another 20 years. I really mean that. We have been collecting representative data of legal and undocumented or unauthorized immigrants in the United States for 2 decades successfully. And until about 5 years ago, many prominent people, some of whom might have been your dissertation advisors at UT Austin, formerly at Chicago, Penn, now at Princeton, many prominent demographers have said, you can't collect legal status data from immigrants, representative data, while we were doing it for 10, 15 years, and they were saying that. What's happened now is a lot of the students of these same people who said this are now publishing papers in demography, doing all kinds of work now with the methodology that we developed 20 years ago. That's vindication, if there ever is any, right? I don't need somebody to say it in front of other people, but when they're doing it now, after they have criticized it for so long, to me that's vindication that it can be done. And it can be done because of the way that Maru and others have taught us how to do it. And that is, you have Mexicans interviewing Mexicans. You don't have me or someone else interviewing Mexican immigrants. You go up respectfully. And I'm not going to talk in great detail about our methodology, but what I'm going to do is to show you what our methodology has done and continues to do, and where I hope it's going to go in collaboration with some of you, starting immediately. So, I'm going to discuss some new estimates I'm doing with almost $500,000 that we were given 8 months ago from a funder called the California Endowment. They gave me and my colleague Manuel Pastor, who is at USC, almost $500,000 to use the methodology we developed 20 years ago and the data we collected to come up with a legal status prediction equation from our data, from 300, 400 people we interview, who tell us whether they're legal or not, and then from that information, collecting other demographic information like age, sex, time living in the United States, etc., we can come up with a prediction equation to apply to other data that's available nationally, census data, health data, etc., that do not have legal status. So by doing this imputation methodology, we're able to do incredible, a lot of things that other people just can't do. And whether you believe those estimates or not is another story, right? That's a whole other question. We believe it, of course, but it's an estimate. These are estimates, not the truth, right? So my interest starting back in 2003, and I can't believe this is more than 10 years ago now, when I went to Harvard. I left economics and I went into public health at Harvard in 2003, stayed there till 2007, and I wanted to come back to Southern California so I could be closer to Kolev. No, I wanted to come back to California to be where I learned this and to continue doing it and working with Mexican immigrants. And so my interest 10 years ago changed from being a labor economist and studying labor migration and labor market outcomes, etc., to wanting to study health. And in particular, why I'm in sociology now is because I'm most interested in the social and geographic environments in which migrants live. And so we look at what is home? What does it mean psychologically and physically, environmentally? How does the home affect migrants' behavior and their health? How does the neighborhood they live in affect their health? How does the workplace? All these different domains of life, we want to try to empirically estimate how important are they in determining differences in psychological distress, mental health, obesity, diabetes, other kinds of health outcomes, while controlling for the environment in which they grew up. And we don't do a very good job of that right now. So for example, we don't have very good data from the municipios and the states from which Mexican migrants came, or Brazilian migrants or Dominican migrants, the other groups we've studied. And that's one direction our work is going. We want to work with you and with a university in Brazil to begin to get better data on the places, the communities from which the migrants came, so that we can better estimate how legal status and the places that migrants live currently in the United States affect their health outcomes. That's one direction it's going to go. I'm giving my punchline away in the beginning of the talk. The second way we are trying to improve what we do is, in addition to collecting data from the communities from which they've come, we want it to be panel data. So we want to collect the first longitudinal data in the United States that follows unauthorized migrants over time. I got a call last week from the Migration Policy Institute and some other colleagues who want me to become involved in designing and implementing a new study to look at how are those who legalized in the late 1980s and early 1990s through the Immigration Reform and Control Act, IRCA, how have those who have legalized, how are they economically in terms of health compared to those who did not legalize, right? You'd be surprised, but there are not many studies that actually look at that. And here in the United States, there's a lot of talk about legalizing migrants again, and people are asking, well, how did it affect migrants 20, 30 years ago, right? these questions are still unknown. I mean, the answers to these questions are still not known very well. So let me get on with it, as they say. I want to just show you quickly, also by way of introduction, the analytical, if you will, or conceptual model that drives what I do. This is really an integration of work that 4 or 5 other people, research teams have done, but it's a diagram that I built because I think it's important when you read other people's work to try to integrate it and make it yours, right? Not to steal it, but to put it in your head in a way that makes sense. And so for me, coming from economics, once again, if I stand, will it be okay to?
Yeah, sure. You can.
Coming from economics.
Let me ask you.
Yeah.
Because they are recording. Okay.
It's okay?
Yeah, they will give you the mic. Yeah, sorry.
That's okay.
It's part of this from.
I like it.
It's very good.
It's very good. Okay. All right. Can you? Yeah. Can you hear me? Okay. That's all right. Okay. So this is a conceptual model of all the factors I think, and if I'm missing something, point it out to me, please. But we have separated all the factors we can think of into very broad categories that might influence health behaviors and health. And so, this comes out of social epidemiology, and there are various names, multi-level factors that influence health behavior and health. It's that, right? If you're familiar with that already, you know where this is coming from. And so, first of all, coming from economics, this is what we as economists always think of as the most important. Your educational attainment, your age, the job that you have, all of these kind of individual level factors is what I started out studying. And, time living in the United States for you related to health outcomes and health behaviors, all individual level factors are here. I split them into socioeconomic status factors, which include legal status, and also health behaviors and health status that could be associated with an outcome of interest, such as obesity or psychological distress. And up here I have what I call socio-geographic factors that are extra individual, or what economists call exogenous factors, right? So, there's the home environment, there's work and school, there are the neighborhood in which you live, civic groups such as a church you might go to, a parent-teacher association, community groups, all kinds of environments. This little portion of the diagram goes outside of the metropolitan area because it could include things like internet-based groups, right? It's not necessarily, your group isn't necessarily geographically defined. Likewise, medical insurance and care is something that may or may not be available to you, may be close proximity to you, but in fact, we could put that down here in health behavior as well, as you may have it offered to you, but you might decide you don't want it, right? So, and as you may or may not know, the Affordable Care Act in the United States explicitly excludes one group of people. Can you guess who they are? Mexicans. No, they're not Mexicans. Unauthorized immigrants. Okay? So that includes some Mexicans, but from any country. That's the only population group that the Affordable Care Act does not provide subsidized insurance for. So that grant I told you about that we got last year from the California Endowment for me to use this methodology to estimate the number of uninsured, unauthorized immigrants in California by county and in very small locations is specifically that. Communities and hospitals want to know how many are here and what are the characteristics compared to people who do have insurance, etc. In any event, what I'm going to talk about today is really I'm just going to focus on one of these factors, which most people think is the most important and I think is the least important for health. And I know that sounds sacrilegious perhaps, but medical insurance and care. In the United States, I grew up having insurance and access to medicine and doctors, and my mother took us to the doctor, the dentist, etc., if we coughed. But when I'm talking about factors that influence health and health behaviors, I happen to think that dentists and doctors, no disrespect at all, are, for the most part, at least in the United States, are rescue-oriented rather than preventive. And so they're very important if you're sick, right? If you need care. But in terms of determining health outcomes and health behaviors, I think where you live, the people with whom you interact, etc., is much more important. And I'm saying this as a hypothesis, not as truth. This is what we're trying to study. But for today, I'm going to contradict myself and focus only on this because that's where we have our current grant. How's that for honesty? Okay, so in the end, I think that all the individual characteristics that you have and have acquired over time, both biological, socioeconomic, etc., interact with the environments in which you live to determine various health outcomes or behaviors. Okay? And stop me at any time if you have any questions. So, what is the background and motivations for the work that we're doing? And when I say background and motivation, I mean not just for studying access to health insurance and medical care among legal and undocumented immigrants, and not just Mexicans here. I'm not talking about just Mexicans. I'm talking about from any country. The background and motivation that I want to talk to you about right now is not just for studying insurance and care, but also for doing the survey work that we do, if that makes sense. So it's the methodological motivation, not just the motivation topically to focus on access to insurance and care. And let me just start by saying that it has been over 3 decades, 30 years, when one of my dissertation advisors, who actually wrote a book here at COLEF by the name of David Hare, a demographer and sociologist, in 1980-81 did the first known, anyway, sample of legal and unauthorized migrants, which allowed him to generate a legal status prediction equation that could be applied to census data to study this systematically, to see how many unauthorized migrants were living at that time in Los Angeles County. He and Jeff Passell, you may know of the Pew Research Center, did a paper in 1987 that compared that methodology to a very different methodology, which is called the residual method, where they compared their estimates and the characteristics to see if they were similar, and they were. And they still, most of the time, these estimates that we make using our survey-based methodology are consistent with this other methodology. In any event, not until the early 1990s, these 2 efforts were the first 2 to collect legal status data, but it wasn't until our survey, Maru, and that we did together with Jorge Bustamante and Santibáñez and Chuy and David Hare and the rest of us graduate students of Los Angeles, that was the first random household survey of any nationality group. It was Mexican immigrants in Los Angeles County. And we randomly selected thousands of houses to knock on their doors. I wasn't involved in that. They were only Mexican immigrants. And Maru was very much involved in the design and implementation of that. Did you actually do some of the interviewing also? A lot of it? Chuy also? Yeah, actually, you probably did most of it. In any event, that methodology then was the basis of everything that I'm doing today, that we've just built on it. So that's the first one. And then what happened was there was a series of other surveys that were done in the 90s and early 2000s of people who started collecting legal status data as well. And yet, all along here, I'll just say it, people like Frank Bean, Doug Massey, these are not lightweights in migration research, right? All along, these people were saying, can't collect credible legal status data from individuals in surveys. Meanwhile, I'm an insecure graduate student thinking to myself, but we're doing it. Is all the work that we're doing not valid or credible? It is, and they were wrong. And it only took me 20 years to be able to say that. And so in 2001, when I was a postdoc at UCLA, I planned and designed the first one that was basically an extension of the 94. Maru and Chuy actually did the training of our interviewers. So again, that was a COLEF, at that time UCLA, not USC, joint project. And then you had prominent demographers like Ann Pebley. I don't know how many of you know of some of these demographers who subsequently designed surveys that also asked legal status questions. So somebody thought that we could do this, other than just us. And then there were some other ones. You know about the Chicago, obviously the one that was done in Chicago that you all did. Then I did it in Boston in 2007. It was a Harvard UMass Boston project with CDC funding that was Brazilians and Dominicans, because at the time there were only about 5,000 Mexicans in Boston. So, but in that project we actually collected biological data as well, saliva, blood samples to obtain biological metrics for stress. In any event, In 2012, we did the last Mexican survey that we completed. We have those data. And then right now, I say in progress, is the one that we're doing in San Diego. And we hope to finish in the next 2 months. And some of you may be helping us with that. Ultimately, though, I want us to begin to use these data to not just write papers, books, perhaps, together, but I wanted to make those 2 improvements in the area of making it longitudinal and also in terms of collecting data in the country or communities of origin. Okay, so in this book chapter, I've only brought 10 or so copies. If you're interested, this just came out last week, and anyone who's interested can grab a copy of that later, I suppose. But I'm not going to go into great detail because it's in there if you want to read it. But basically, I make the argument in the introduction that there are 3 reasons why studying migrant health is difficult. The first is that health per se is not a tangible biological event that is defined, and it is defined and measured in many different ways. So when you say you're studying migrant health, what do you mean, right? What's a migrant? What is health? Both these terms are up for debate and discussion. Secondly, representative survey data that include migration and health variables often exclude information about those different life domains that I talked about that I think are important for actually understanding variation in health behaviors and health outcomes. And lastly, I know we wouldn't include ourselves in this, but many of us have strong, and in statistical terminology that's called biased, feelings about immigration and how that influences. So our feelings influence how we interpret data, even if they are unbiased in how they're collected, which is never the case anyway. But my point is that for these 3 reasons, it's difficult to study migrant health, and especially the social and geographic domains. I'm going to go through these next couple slides very quickly because I want to leave some time for discussion. But basically, this was the first paper I ever published that explicitly looked at access to insurance and care, and this was published by you. It's in Migraciones Internacionales, and it used our 2001 data. And basically, our finding here was interesting in the following sense. We estimated what are the percentage of unauthorized, legal, Mexican migrants in California who had insurance coverage compared to all other groups, right? And what we found was that, to no surprise, almost 2/3 of unauthorized Mexican and other Latinos in California lacked health insurance. About half of those who have legal permanent residency lacked insurance, and less than 1/3 of all other groups, meaning U.S. citizens for the most part, lacked insurance. So there's great disparity, right, in who has access to insurance and who doesn't. And this is why I think people care about it. But still, in the current U.S. policy, this is the only group that's left out of coverage. We also found, to nobody's surprise, that most of the time when unauthorized migrants accessed the medical care system, they paid for it themselves. This is out of their own pocket. And then when they went, where they got it, were mostly in community clinics. All right, there's no surprises here. I just want to say that the punchline to that study is that although unauthorized status was negatively associated with Mexican migrants having health insurance, neither legal status nor having insurance was statistically associated with whether they got the medical care that they say they needed. Rather, legal status, unauthorized status, worked through the various domains of life, such as their social networks, such as the neighborhood they lived in, etc. That is what explained whether or not they got the care that they needed, not whether they were undocumented or not. And this, to me, is really interesting because it says the social epidemiological model is very applicable to studying legal status influence on health outcomes. So I got this out of the paper yesterday and today. Just the last 2 days, we see that there's a big push to get people signed up for health insurance. There are currently over 7 million people who, for last October, got insurance in the United States because of the Affordable Care Act, or Obamacare. 112,000 people so far were kicked out because the government couldn't prove that they had legal status. So they're really doing this. They're checking to see if they have legal status, and they're not including them if they don't. This is that grant I told you about that we have right now, and in these results that I'm going to show you just at the end of this talk, I'm going to show you what we're finding out about where unauthorized immigrants in California are living and what proportion of them are uninsured. And this stuff isn't even released yet. It'll be released in the next couple of weeks, these new estimates. So what is the analytical approach? I won't say any more about that because I've already shown you. This is the analytical approach in terms of how we separate variables and we think about factors influencing. In this case, it would be access to care, right? Or actual being insured. It wouldn't be obesity. And so very, very quickly, I'm just going to run through these next slides because I'm going to summarize for you decades of research in like 5 slides that show the effect of various individual characteristics or life domains on stress, but you could interpret this also as having an effect on health. Right? Stress is just one measure of health, right? So what this means is that females, those who are black, migration, approaching middle age are all positively associated with stress, or you could argue poor health. In terms of socioeconomic status, we find that most socioeconomic status variables, however defined, education, income, occupation, you name it, so there are other ways to measure it, home ownership, etc., right? Those are typically negatively associated with poor health outcomes. So the higher your socioeconomic status, the less stressed you are, typically, and in better health you are. None of this will come as a surprise to you. Here's evidence coming out of where you live. You know, neighborhood disorder, poverty, ethno-racial diversity are bad for your health, believe it or not. I know we like to think that diversity is a good thing, but research tends to suggest that it's not necessarily a good thing for your health. Social cohesion improves your health. That is, it's negatively related to poor health outcomes. In terms of home environment, ownership, marriage are negatively associated with stress or positively associated with health. Having children and being a single mother, for the most part, have been shown to be detrimental to your health. I want to just say something briefly about this study because it's had a very profound influence on my thinking. It's by a sociologist, Bruin, and a medical researcher by the name of Wolf, published in the late 1970s, and still I think it's one of the best examples of this conceptual framework that I'm talking about. These researchers showed near to where I was born, in Norristown, Pennsylvania, down here, I was born there, in Pennsylvania. They showed that the Italians, that didn't have an influence on me because of their Italians, but the Italians who lived in Roseto, it's called The Roseto Story, is this book. Rosetto's somewhere in there. I don't know where it is, but it's somewhere in here. Roseto, right there. They compared the Italian Americans living there to those who lived in Nazareth, and I believe the other place was Bangor. I could be wrong about that second place, but they compared it to 2 other places. Why? They noticed an empirical anomaly. All the people who lived, the Italians who were living in Roseto had lower mortality due to cardiovascular disease. They had less mental health, fewer mental health issues. They were living longer, and yet they were the same, if you will, genetic background, ethno-racial background, nativity background as the Italian Americans who were living in another place. In fact, many of the people who lived in Nazareth and Bangor moved from Roseto into these other places. And the amazing thing was, what was found there, they had the same prevalence of smoking. They had this very, very similar diets. I grew up eating pig's feet and tripe and I don't even know if you know what these things are. I know you know what pig's feet are. But we ate a lot of foods that a lot of other Americans don't or didn't. And these Italians did. But the people in Roseto were living longer, were healthier. For some reason that was not related to behavior, not related to biology, it appeared. And what these researchers concluded in this book is that it had to do with their home and their neighborhood environment. And this is a great book, a simple book, no regression analysis, no fancy statistics, just straightforward, empirical, looking at what are the characteristics of these people and how do they vary from place to place. So I've already told you I will send you a copy of this book chapter if you want it that just came out that explains the methodology I'm using, and we don't have a lot of time here, so I'm not going to go into great detail. I'm hoping that I can convince some of you, though, to help us in San Diego to finish our survey in the next 6 weeks or so. I have 20 students right now, 10 teams, and I'm hoping to work with some of you. You can stay afterwards if you want to talk to me about that. But for now, in that book chapter, I basically talk about the study we did in Boston, which was of Brazilians and Dominicans. Usually we collect about 300 completed questionnaires from adults. That includes sections such as your migration history, your socioeconomic status, your social networks and civic groups you participate in, health outcomes and behaviors, and then social and political identity and behaviors. We collected over the course of several months, and here's just a picture of when we were in Boston, the different places we collected these data. Again, remember we did it for Dominicans and Brazilians, but here are just the four different kind of locations within the Boston, Cambridge, Quincy metropolitan area where we actually listed over 6,000 households and knocked on doors to get 300 completed questionnaires, right? So this is a lot of work, right? And then these are the Dominicans. We had over 600 completed questionnaires in these places. Here's really the punchline I wanted to get to. In that book chapter, it explains this, but what I wanted to show you was this. I did some regression model to try to, controlling for the interviewees, the respondents' characteristics, I wanted to test two hypotheses about the characteristics of the interviewers to understand better who would answer questions about sexual behavior. Sensitive question, right? Who would give us blood? Who would give us saliva? Who would allow us to touch them to measure their weight, their height, and get their blood pressure? And what we found, here's just the results for blood droplets, which we consider to be the most sensitive, right? To give blood, you're unauthorized, living in the United States, and you're going to give some stranger your blood, right? They did. We're the only research team that ever has collected those data from undocumented immigrants. So we have a good position, I think, to collaborate together. If we can collect those data there and work with you to collect data back in their home communities and do this over time, we will be leading the way, I think, in some very important research. And so what we found was this. I tested two hypotheses. One's called the experience hypothesis. And so that would be, how many interviews did you complete? And how old are you? Those could be used as markers, if you will, for how experienced are you, right? We also measured educational attainment and skin color as markers for another hypothesis that we call the deference hypothesis. Actually, I don't. Survey methodologists, my colleagues, these are their hypotheses. I'm just testing it. And what we found, actually, the punchline to this, and it's true with saliva, sexual partners, what ends up happening, and this is great news, is that it's not experience that it determines how successful interviewers are out in the field. It's not their experience. It's really, it has to do with how the respondents are perceiving you when you come to the door. Are you respectful? Are you someone they perceive as someone who's genuine, there to collect information that's helpful potentially to them or not? It's not whether you're an expert or have had many, many years in training. And so we found, college education. We found skin color. So the whiter you are, the more likely these were Brazilians. The whiter you are as an interviewer, the more likely people are to answer or to respond to you. Is that the same for Mexicans? I don't know, because we've never done the study. But with Brazilians, it was true. So it seems like characteristics rather than experience better explains whether or not immigrants, are unauthorized and legal, are going to give you sensitive information. So the take-home messages for there, please don't read this, just look at me. It's too busy. The take-home messages are just that, over 2 decades of work, we've shown that not only are legal and unauthorized immigrants willing to give us sensitive legal status information, but also sensitive health data, which a lot of people, my colleagues, don't believe that they would ever give you, including biological data. Secondly, the probability of providing biological and behavioral data, which is important for migrants because they're typically younger, right? Rather than just self-reported data, is conditioned on the level and sensitivity associated with the outcome, so sexual partners, saliva, blood, and unaffected by legal status. That's a surprise, right? Most people say if you're unauthorized, you're going to be much less likely to give it, and we didn't find that. And lastly, biomarker, not just sexual behavior results, support the deference rather than the experience hypothesis. So we've had a bunch of publications, over 50, as Rodolfo said now, in journal articles and book chapters, all that have come out using this methodology. These are just some of the more recent ones, including media coverage. This is just in May this past summer, and here's the most recent one that you can see the uncorrected proofs, Journal of Urban Health, where we're looking at neighborhood social characteristics and how they affect various markers of psychological or physiological distress. So in 2001, and then again in 2012, you might recognize somebody up there, right? That was the only picture I could find from 20 years of working together. We should have taken more pictures, Maru. But this was back in 2001 when I was at UCLA. This is the group up at Chirla, a community-based organization in LA, and the 2012 CDC-funded project. And in this project that I was briefly telling you about, I'll show you these results and then stop talking. I used the legal status predictors from 2001 and then in 2012, and they change over time, right, to apply to the 2008 to 2012 American Community Survey data, census data. And the 2012 data, collected a little over 300 questionnaires and estimates a number of foreign-born Mexicans that's very similar to what you get after we weight the data using the inverse of the probability of selection. Weight the data, it comes very close to what the Census Bureau says there is. And in terms of our estimated number of unauthorized, very similar to what my colleague Jeff Passell gets using a very different methodology. And so the real benefit of what we do is not only can we have this legal status prediction equation that we can apply to public use data to study health outcomes and economic outcomes, but we have all this social geographical domain information that we can use the data themselves, not in conjunction with public use data, to estimate how these various life domains affect different health outcomes of interest. And that's where I hope some of you, I don't know how many of you are graduate students here or faculty, but I hope some of you we can get interested in writing a chapter that we will edit together as a book. The data are available, they're underutilized, and we need to start using them. So I hope you'll consider joining us in that. The American Community Survey data has a question, the survey has a question that asks, is this person currently covered by any of the following types of health insurance? And there are the 1, 2, 3, 4, 5, 6, 7, 8, however many are there. Yes or no. And so I use those questions then to compartmentalize these different types of options into private insurance, public insurance, and private/public insurance. That means you can have private insurance, you could have public insurance, but some people actually have both. And a lot of researchers don't even consider this. But anyway, for the purposes of what I'm going to show you right now in results, I'm only estimating how many people don't have any of those. So I don't want to spend too much time on this. And the preliminary results are this. Here's a map. You can see the lighter colors represents lower proportions of unauthorized migrants living, and this is by all the different counties in California. Again, this isn't published yet, and we will eventually. But here you can see, like for San Diego County, it looks like there's between 5 and 8% of the population that's unauthorized. Immigrants, not Mexican only, any kind of nationality, okay? And then you can see Los Angeles, to no surprise, and some of these other places have higher proportions, but nowhere does it go above 13%. The funding wasn't for this. The funding was for this. Next slide. And this is of unauthorized foreign-born residents lacking medical care or medical insurance, what percent are uninsured? And here you can see that that ranges from 0 to almost 74%. Remember from my study from 2004 that you published, thank you for publishing that, those estimates that said about 2/3 of all unauthorized Mexicans and other Latinos lack insurance. Here it's a similar range, right? But you can see that they're concentrated in certain counties, not up in the northern part of California, and interestingly, not in San Diego or Imperial counties. So we weren't given the money just to do county level estimates. The real advantage of our methodology is that once you have that legal status prediction equation, if you have data like census data that have many, many observations, and I need to stop in just a moment. If you have many, many observations, like we do in the American Community Survey, millions in fact, right, for California, then potentially I can do estimates at very local levels, which is where people care about population characteristics anyway, right, where you live. And so we went down here, I don't know how many of you know San Diego County very well, but City Heights is just next to San Diego State University, not 10 minutes from where I live. It's where we have what we call the Mexican Soccer League. My two güeritos play in that league. And so I go there every Friday night, every Sunday. I'm there for at least 4 or 5 games of soccer. And, but in City Heights, the California Endowment 10 years ago picked that over my objection. I wanted them to pick Barrio Logan, and they picked this place. To do what? In 10 years, the California Endowment will spend $10 billion to try to improve the health of people who live in 14 places in California. This is one of them. And the first thing they're doing is wanting to increase access to insurance and care. So my work right now, basically, is to help distribute only 20 million of the 10 billion. Again, this isn't publicly known, but I don't care. $20 million is soon going to become available from this foundation. And they paid us up front for me to estimate how many live in these different places and what proportion of them lack insurance. But I don't really care so much about that. As I told you, I think it's one of the least important things determining health outcomes. I'm more interested in convincing them they should be studying the home environment, the neighborhood in which they live, the workplace, etc. And so, but right here you can see City Heights has a higher proportion of unauthorized immigrants who lack insurance, almost 70%, compared to unauthorized migrants throughout the county, about 61%. These are the kind of estimates that we've done for this project. And like I said, these aren't even published yet. These are just the proofs that'll be coming out next week or so. So that's what we're doing right now. We're providing a bunch of, I created all these tables with a lot of different characteristics, where they're from. You can't read that, so don't bother trying. I'm just showing we have a lot of characteristics about the children, about unauthorized migrants, where do they come from, etc. And then moving forward, just to conclude, I've said it twice, I'll say it again, because I find with 2 little boys, sometimes it takes at least 3 times for people to, at least the little people, to remember it. And where we're going with this is basically first finishing our survey in San Diego, which is with, I'm happy to report, with Rodolfo and some of you, I hope. And we are working with Enrique A and Angeles de la Frontera, or Border Angels, as it's also known, to complete our questionnaires. We already have over 200 completed. We need a minimum of 300. Why? Because as you know, you need at least 300 to have a certain margin of error on any variable. And so I'll stop there, and thank you again for inviting me back. I hope this, again, is a reestablishment and a new beginning, so to speak, of getting back to this work that we started 2 decades ago. So thank you.
Muchas gracias, Enrico. Pues fue mucha información, ¿verdad?, en tan poquito tiempo. Pero tienen algunos, abrimos preguntas, comentarios. Yola.
I understand you made a household survey and you interview illegal migrants. Okay. How was your non-response rates? Or because I did have an experience doing a pilot test in California also, and the pilot test resulted in the survey not being carried out because it was very high.
What was
it was very difficult for us to have the people selected accept
Yes.
the interview. It was really very hard. So we ended up with a very high non-response rates. It was a pilot test, but in any case, it was decided not to carry out the survey. And we didn't do straight interviews. We used Akasi computers. You know. They were
Yes.
by themselves completing the questionnaires. So I'm really surprised that you. Well, I thought I had experience.
I'm sorry, what is your name, by the way?
Yolanda Palma.
We've met, actually, before. I don't know if you remember. Here, at Cola. But anyway.
Perhaps, yes.
What, you don't remember? So I want to say this. First of all, you're the first person to ever ask that question. No, I'm kidding, of course. I have heard this question for 2 decades. It's an important question. 2 questions, really. First of all, I want to say this. You've just described a different methodology. We have not gone into homes with computers on purpose. Because I think walking into a home, first of all, with a computer may be a little more intimidating than just standing out front with your picture and a reputable community-based organization next to your name and a university. But I hope we get to the point where we can use computers, actually. But so there's a methodological difference in the way that you did it, and I'd be curious to talk with you afterwards about more details about the methodology. You know as well as I do that it can take 1 or 2 little things to completely change the response rate.
Yeah.
Secondly, as I know you know, a lot of people think that you can't get accurate estimates if you have a high non-response rate. And that actually is not always true. As you know, let me just finish. As you know, what matters is if the differences are systematic, right?
Okay.
In the people who are responding, okay? So I will first say that our non-response rate is as high as it has been in the American Community Survey, which is now the dominant census data collection methodology in the United States, in neighborhoods that have high proportions of minorities, not just Mexican and immigrants, but also non-Latino blacks, for example, U.S. born even. So, I'll answer it the other way. Our response rates range between 60 and 70%. All right, so not high, not nearly as high as you'd like it to be, but you have to remember the populations we're dealing with, that 40 to 70% of the populations are unauthorized. And again, I will just repeat this. What matters in terms of whether the data you're collecting ultimately is whether the people who are not responding to, in other words, is it just the unauthorized who are not responding to your questionnaires, right? And not only non-response in terms of completing the survey or participating, but what is the non-response rate of particular questions, right, within the questionnaire? So we've had more problems with that, to be honest, Yolanda, than we've had with the problem with the non-response. We've gone back and tried to estimate how systematically different the people who are not responding to our questions are from those who do answer, and we've actually found we haven't found great differences. Most of the reason why people don't respond is because they're too busy. It's not because they're afraid. Look, Maru was interviewing. When a Mexican woman comes to your house and knocks on your door, and I don't know if you went to the doors knocking or if it was a household survey even, I don't know. I'll have to learn more.
Household, yeah.
It was household,
yeah,
door to door.
Yeah.
And where was it? Where?
In California.
Where in California?
Los Angeles, San Diego,
So I would love to talk.
Escondido.
I would love to talk to you more. You should have worked with Maru.
Yeah.
I'm joking, of course. And I don't mean to make fun or light of your experience, but
No.
all I can say is that we are always trying to raise the response rate. And we've had difficulties. We had more difficulty with Brazilians, to be honest with you, than we did with Mexicans or Dominicans.
We had about a 50% response.
Yeah.
50.
Yeah.
And believe it or not,
Well, we thought that was very low.
it is very low, but I think you have to put it in the context. I mean,
Yeah.
if you look at the American Community Survey, look at the Census Bureau, and look at what they report for their response rates for hard-to-reach populations and communities. It's not much higher. And in fact, David Hare's 1980-81 survey, if you look at that response rate, it was 58%, I think it was, 57, 58%. And so, yeah, I mean, you could criticize it for that. Ultimately, I think you have to compare the characteristics of your respondents and the estimates that you have with other sources and see if it confirms or disconfirms. And we have found both ethnographic, anthropological, and other quantitative estimates actually confirm, not always perfectly, but to a great extent it confirms the characteristics, age, sex, the basic time in the United States that we're estimating. We're either very, very lucky each time or we're doing something right. So I really appreciate your question, but I do want to talk to you after if you have some time. Thanks.
Thank you.
¿Alguien más? Roberto. Mariano.
Dr. Marcelli. So on one of the initial graphs you showed, it appeared that So Hispanics have both undocumented and documented. They have like the highest rates of uninsured populations, right? So
Right.
I mean, there doesn't seem to be like a difference between documented and undocumented. Did you find in your studies, is there a cultural factor for this?
No, I think, what is your name?
Miguel.
Miguel? Thanks for your question, Miguel. I think I went through the slide too quickly for you to see it properly. The two lines at the top
Right.
in the Migraciones Internacionales article are actually both undocumented.
Oh, okay.
The next group are legal. I just separated Mexicans from other non-Cuban Latinos. So the two top ones are all Latinos unauthorized. The next group are legal Latinos, Mexicans separated from others, and then everybody else. So we do find systematically that unauthorized migrants always have a higher proportion not covered than legals.
Thanks.
Does that clarify that question? Yeah. So I'm sorry I rushed through it, but I had too many slides.
Yes, too many information. Robert?
Well, I don't really have questions, but
Uh-oh.
some-
I better sit down now.
yeah, you're too sarcastic, so I don't really raise that. Well, the first thing is that I am quite surprised that you have all those surveys. I didn't know about that, and I would like to know a little bit about the background of all those studies, and I am not asking you about it, but asking you if we have access, where do you have access to these materials? For instance, I would like to know the technicalities of the survey, the method, the selection method, the size of the surveys, these concepts that you have used, and also I would like to know if we can see somewhere a copy of the questionnaire. That will be very, very important. Do we have access online on that, or how can we ask for that? I think that the most important people right now in this room are the students. Students.
Yeah.
Sorry about that. It's
Yeah.
okay.
No,
Students.
gracias por trabajar.
You're not a student, you're a students. Okay. The students, some of them are looking for a topic to not just to write a thesis, but also to make a living, right?
Yes, absolutely.
And I wonder if these things that you have here could give us a chance to go with the students on that. That's the comment.
No, thank you for your questions, actually, and your comments. These are very important. So let me answer the first question that was about access to, or you didn't know about all these studies. First of all, most of the studies I listed up there are not ours, right? Most of them are other people. But the 4 or 5 that I listed up there, these are data I have myself. And we have not had the resources to even write the data dictionary, to give you an example, right? So it's embarrassing. I'm embarrassed to say that. But we're trying to, right now, actually I have students working, trying to write out every variable, the position in the data, all that, to try to make it available for use. So we're working on that. But anyone who's interested in using the more recent data, I'm committing myself to saying, if we can identify a topic and the variables that are of interest to you, I will personally, with a research assistant, get those variables ready and give them to you. Under some conditions, right, that we don't share them with other people and that we can agree on authorship and use of them. But my interest is actually having them used. We've had these data too long and we don't publish enough with them. There's too much there. And besides that, you've helped, a lot. And we've only done a few things together. So my short answer is, in principle, I will make the data available. Am I going to just send you a file with everything? No. I'm going to ask you what you want to study after you look through the questionnaire and say which variables are you interested in, and then make sure nobody else is already doing it. But for the most part, I only have 4 or 5 students working right now. There's plenty of data there to do plenty of different papers, right? You could focus on women only. You could take the 2001 and the 2012 data for the Mexicans only and do a paper on women and health. They're not big data sets, right? There's only 300 So if you take just the women, it's half. It's 300 for years 2001 and 2012. You know, it's not big. We've constructed the weights. I have to tell you, Jorge Santibanez is the one who taught me how to construct the weights 15 years ago. So the first time I ever constructed sample weights, I did it with him, sitting down at my kitchen table, and him teaching me how to do it. So I don't know how much, I'm not sure I answered all your questions, but in principle I'm saying I want to collaborate with you, I want to publish. I think it's a shame that especially for the first survey, you helped collect the data and then we never used them together. So let's go back. Let's go back and use them. And let's get some money together. Let's go after some grants together so we can pay your students and get you off on your career, like you helped me get off on my career, actually. I'm serious about that.
Okay.
So
how can we get the questionnaires?
I can send them to you.
Okay.
I'll send you questionnaires. But again, I have to have your word that your promise, yeah.
I deny.
You deny. Well, then you're not getting it. No, I mean, the point is that, most of what we ask is out there in the public domain anyway. We're not doing anything secretive. We have some questions that are unique. So, yes, I'll share the questionnaires with you. Read through them, see if there's something you could use or you wish to study. Then we'll go back and pick off the variables and sample weights, and we can use them.
Okay, I wanted to say that your talk is very illustrative of what is important for us now, and for me especially. I totally agree that social determinants of health are more than access to health. And we have been looking over some data about elders that in the U.S. that show us that although the access to health is there and the campaigns are knocking on the doors of the Mexicans, of the aging Mexicans in the U.S., they do not use the information. We, with Roberto, made some analysis on arthritis, and people and elders do not use the arthritis information. They need to prevent what's going on with their health. So the campaigns are in Spanish. They knock their doors and invite them to do many things. So the access is not the issue.
Right.
The access, what I think, is something culturally. Are there any cultural variables in this survey that you have been doing?
So this gets back to also your comments and questions. So here's an example of some of the questions we ask, just because I was trained in social epidemiology and thinking about these issues. I don't know if anyone else is asking them. We came up with them on our own. I don't know how good they are. I'm being honest. We don't know how good they are, but here's an example. We ask questions such as, how many times per week do you eat at home with your family or with the people you live with? That's very simple. But believe it or not, these aren't asked in public use data. Secondly, how many days per week do you cook at home? And then two follow-up questions are, if you answer that you eat at home or cook at home any day, how much time do you spend preparing? Who prepares the meal? Is it a woman? Does the man help? Then how much time do you actually sit together to eat? Now, we asked this about what was it like in the home you grew up in Mexico, and what is it like now? So I've never seen these in any other questionnaire, but we're trying to think about, and in collaboration with my Mexican colleagues, I didn't just come up with this myself, we think about this and we try to understand. There's questions in there that come from the CDC, actually, that ask about the use of ceramic cookware, which you know has lead and can be detrimental to your health. So we have some of those questions, but we don't have a lot. We ask some simple questions. We ask another question about the percentage of the work that's done in the household. What percentage of that work is done by a woman? And that changes dramatically from women who live in Mexico and when they come and live in the United States. So we're trying to capture some cultural aspects, not just what language do you speak in the house, but we have a long way to go. And this is why I think collaborating could be fruitful, because you know better. I don't know what questions to ask about how to capture cultural nuances that might be influencing why information and access are relatively unimportant. This is an old public health model. Just throw information at people and that's what you have to do, right? We know that. We know that that doesn't work, not just for the elderly, but for most. So anyway, that's my quick answer, and those are just two examples. We have other questions that try to get at cultural aspects of, but I don't remember them off the top of my head.
I think this is very important that you come here at COLEF and talk about this kind of methodology, and perhaps we remember what those days and working in this new methodology and collecting data on household surveys. But this institution, it had been, COLEF had been one of the major institutions in Mexico collecting data and doing research on migration and migrant.
Of course.
But also with things that the methodology issues. MIF, Cañón Zapata, and many other stuff have been working. So this is a new things that Enrico had been working for a lot of years in US. I think we are, as Department of Study, population, students, and professor, we are prepared to doing new things and new methodologies to collect data on migrants, and perhaps not just migrants, perhaps health issues, older, and many other issues but trying to pick up data, and new data that shows another aspect of the phenomenon, the social phenomenon that we are studying here. So that is the reason I think it is very enthusiastic, this project with San Diego State, with you specifically, Enrico, because we can do new things in these issues.
I want to just follow up with this and say only this, that I hope you don't perceive from what I'm saying that we were the first to collect blood samples, or the first. I am not saying that we're doing it the best or that we can improve. In fact, I am here saying to you that we can't do it as well alone. We can do it better together. That's my point. And I hope we will. And I hope we can learn from each other and not have egos be what drive us. I'm fortunate to be, I'm going to be 50 years old in January. I'm sorry to say, but
really?
It takes, man. You know, it's taken me some years and one of the great things about aging, those of you who are not 50, one of the great things about aging, in my opinion, is that you start to care more, in my opinion anyway, you start to let go of some of the questions and the things that gave you stress when you were younger. Not everything, but you can begin. I mean, I have a position that I'm tenured at San Diego State. I don't have to worry about impressing anyone in terms of getting a new grant or publishing in the top journal, or this is, no, do you understand what I'm saying, where I'm coming from? I really am interested in helping students start their careers. I only have 10 or 20 more years left in this game. What's going to be left after that, right? What's after that?
Well,
I won't know.
I'm 75, so
okay, maybe
you can
I had 25 more
I don't
years.
have anything left to let go.
Eunice.
I just want to thank you for coming here at COLEF. I think it's been very interesting to see what you are doing at San Diego. And I have two questions. The first one is why this site at San Diego? Because you said that you were surprised and it was almost your hometown. Where you said that they pick up the county or that area where that is very close to your.
Why do they pick City
Yeah.
Heights? You mean? Yes.
And the other question is about what will be like a common day of interviews at San Diego. You have doctors involved. What's to give the students like the idea of what they will be doing if they participate with you in the
So
in data collection.
Yeah, thank you. So the first question, the California Endowment picked City Heights over my recommendation because I'm often wrong. No, because really what drove it was this. There was the Price Foundation, Robert Price, who started what now has become Costco. He lives in my neighborhood. I met with him privately. The Price Foundation has a well-established history in City Heights, working with community-based organizations, and the California Endowment wanted to invest somewhere where there's already networks and a history. They want to invest where it will have an impact. In Barrio Logan, there was a foundation, the Jacobs Center, which I know well, and is not as well established as and so they went with, I think they went with the place that is more established. Okay, does that answer? They're both places that have relatively impoverished populations, many immigrants, etc. I thought if I had all that money, I'd want to put it in the poorer place. That was my perspective, not theirs. I understand, they're investors. The second question, the training, Mario can tell you this because she has been the one to do it. I don't do the training myself usually. I do it with colleagues from Mexico or from Brazil or from the Dominican Republic. I help to write the questionnaire with colleagues and the community-based organization working with migrants. We then take it, translate it, and over 2 to 3 days, we train the interviewers on the protocol, how to approach households respectfully, what to wear, what to say, what to be careful of, how to protect themselves, the whole thing in 2 to 3 days. That's it. But I've been working with the students I have right now, the 20 interviewers, for 2 months, and I still haven't sent them out because I will not until I have community partner and a colleague from the other country to join me. I don't want to do it ourselves. Could we? Yes. In fact, we could. I don't need to have COLEF or Border Angels on there. It will still work. So it's not about need, it's about the right thing. In my opinion, it has a better chance of succeeding, higher response rates, and it's the model I want to teach. And it's much more fun to collaborate, right? So I want my students interacting with you, and I want you interacting with them, and it's a lot more fun and enjoyable to do that together, I think. So the short answer is it really only takes a couple of days to teach someone how to do this. And I always partner a new interviewer up with an experienced interviewer who's done it in the past, so that when they go out in the field, one person is asking the question, the other person is writing down the answers. So you get trained in the field also by somebody who's experienced. Does that answer?
And also because you said that you had like, ¿cómo se llaman los médicos? Las muestras de saliva, that you had samples and these kind of things.
In the Mexican, we've never collected blood or saliva or anything from Mexicans.
That was my question.
We're not doing it right now.
Maybe you needed like to have some previous experience.
For this one,
No, but listen, even for the one where we collect blood and saliva, you do not need nurses, you do not need doctors. You can be trained in a matter of a few hours and practicing to go out and do this non-invasive saliva swab and blood. It's not blood in a needle. It's just droplets on a piece of paper. But there's a protocol to protect those samples, to make sure that they're going to be valid when they're frozen and we can use them. Right? There's a strict protocol that we teach. And I have neuroendocrinologists and doctor friends, colleagues of mine actually do that training if we were to do that. Right now, we only have a scale, a height rod, and a blood pressure monitor. We're just collecting height, weight, and blood pressure. That's it. And anybody can do that. There's still a protocol that we have to teach. You have to be sitting with your hand over your heart. For the height and weight, same thing. There's a protocol, but these are pretty simple to teach. And there's an article in Demography by Tom McDade that's wonderful, that talks about blood droplets, the most invasive procedure. If you want to look at that article, published in 2004, I think. Tom McDade is in anthropology at Northwestern University, and he's published a wonderful article on how people who are non-medical can collect blood in the field in random household surveys. It's not, most people think you can't do it, but we've shown, again, only 50 to 60% of the respondents agree. So it's not everybody, right? We're not doing that now, though, so just so you know, we're not doing that. We want to with the next project.
Anyone? Somebody else? Nope. Okay,
Thank you very much.
thank you very much, and